Hi, my name is Dr. Paul Yong. I'm a gynecologist with a fellowship in endometriosis, pelvic pain, and advanced laparoscopy. I'm a gynecologist at the BC Women's Center for Pelvic Pain and Endometriosis in Vancouver, Canada, where I am also research director. I am an associate professor at the University of British Columbia, and I hold a Canada Research Chair in endometriosis and pelvic pain. Well, for chronic pelvic pain in endometriosis, one thing that makes it unique is that there are three recognized types of pain now based on international guidelines. So one is called nociceptive, one is called neuropathic, one is called nociplastic. And endometriosis is a disease that can be associated with all three types of pain. So that makes it unique compared to other conditions such as fibromyalgia, which is primarily nociplastic. So in terms of definitions, nociceptive pain in endometriosis arises from when endometriosis causes inflammation locally around itself, and also when endometriosis is invasive and invades structures or organs in the pelvis. The second type is neuropathic. That's when endometriosis is so invasive, it actually invades into a discrete peripheral nerve, and then that results in symptoms that correspond to that nerve. And then the third type of pain, nociplastic, is thought to be a result of changes in the central nervous system, such that patients start to develop widespread pain and also a range of other symptoms as well beyond pain. So the challenge, one of the challenges in endometriosis, particularly when we care for patients with endometriosis at our clinic, is trying to determine of those three types of pain, which ones are active or the most active in the patient who's in front of us. Is this pain mostly nociceptive or neuropathic or nociplastic? And again, the complication is that someone could have only one type of pain, only nociceptive. Someone can have two types, someone can have all three types that are actively contributing to the pain. It's nociplastic, neuropathic, and nociplastic. So the reason why this is important is so that the patient understands what's happening in terms of the physiology of what's leading to this pain. But phenotyping by those three types of pain also guides recommendations for treatment. So one part of it is the actual progression of the endometriosis lesions themselves. But that's different from symptom progression because, as is well recognized now, that endometriosis anatomical disease is only marginally correlated to the actual symptoms that the patient feels. But in terms of the actual anatomic disease of endometriosis, the lesions themselves, there have been studies done where surgery was performed and then repeated 6 months later. You can see that in a certain proportion, the endometriosis stays the same. Another proportion, it gets better on its own. And another proportion, it worsens over time. So that raises the question, or what are the factors contributing to disease progression at each stage? So the data here that I'm aware of that's most informative is when someone has surgery and then treatment of endometriosis, and then what variables are associated with the actual endometriosis lesions returning. And for that, there have been several studies. An important one recently published from Australia. Amongst the important variables were the amount of endometriosis at that initial surgery. So the more severe anatomical subtypes, i.e. higher stage, although the surgical staging of endometriosis is currently under a lot of examination in terms of how to improve it. It does capture to some degree the amount of endometriosis, and that does seem to correlate with a chance of endometriosis recurring or coming back, which is a form of progression. Another variable that was important in that study was the coexistence of adenomyosis of the uterus. So if that was also present in patients with endometriosis, it seems that that plays a role as well in endometriosis recurrence/progression. So, in terms of what general gynecologists or other healthcare providers can do to prevent or slow down disease progression, I think this is a twofold question. So, first of all, there's the issue of endometriosis, the actual lesions, the anatomic disease. How do you prevent progression? And the data here is best for the ovarian endometriomas, particularly if one has had surgery to remove an ovarian endometrioma cyst. The data is quite good that medical therapy for hormonal suppression of estrogen will significantly reduce the chance of that ovarian endometrioma coming back. So that's where an area where there's good evidence. A second way to look at this, however, is not just disease progression, but symptom progression, because again, the anatomical disease only marginally correlates to the actual symptoms. So it's also important to prevent or slow down symptom progression because if the patient continues to experience pain, for example, an adolescent who has painful periods every month that's not treated, the result is a process called hyperalgesic priming of the nervous system, and then that predisposes the patient to develop more chronic and even more severe pain in the future. So we say it's important that pain itself, pelvic pain itself, be first validated, recognized to be important, and that pain be treated as well. And so that by treating the pain earlier, that hopefully will prevent the development of worse pain in the future.